Nice to meet you. Welcome, everyone. I'm Hyung from Incheon Sejong Hospital. Today, I'll talk about anatomical consideration for transcatheter intervention. This is the contents. I will look at the mitral valve and tricuspid valve anatomy, and then we'll compare. And then I'll talk about procedural consideration. So transcatheter heart valve intervention have revolutionized the treatment of structural heart disease like this. And why transcatheter approach for mitral and tricuspid valve? The complex anatomy of mitral and tricuspid valve make open heart surgery challenging. So while transcatheter method provide minimal invasive alternative. So these are evidences for the intervention. So why anatomy matters in transcatheter valve intervention? In this study demonstration, the patient underwent TMVR with certain anatomical features like this, have a higher risk of LVOT obstruction and a severe complication often related to anatomical constraints. And in this study, they studied for tear in the neck. They showed the success rate of mitral clip procedure due to altered leaflet mobility and poor coaptations. And this is for the tricuspid valve. So severe annular dilatation and leaflet tethering is correlated to the higher procedure failure and recurrence of tricuspid regurgitation. Also, anatomical variations of the tricuspid valve reflect morphology, such as larger coaptation gap were associated with poorer outcomes in edge-to-edge repair of tricuspid valve. And next, we'll talk about mitral valve anatomy. As you can see here, mitral valve contains mitral annulus, leaflet, chorda, and papillary muscle. The first one is mitral annulus. The mitral annulus is dynamic structure that changes shape throughout the cardiac cycle. And it is saddle-shaped, non-planar morphology, minimize reflex stress. So the annular dilatation is common in mitral regurgitation, especially in the LV dilation. The next one is the leaflet. The mitral valve has two leaflets, anterior and posterior. Anterior leaflet is larger, thicker, and contributing to the 1/3 of the annular circumference. The posterior leaflet is thinner, more flexible. So anterior leaflet is more fixed than posterior, causing the posterior leaflet to be more prone to remodeling and distortion and shape damage. In this picture, we can see that there is a rough zone, which is coaptation line, and clear zone here. So we will accord like this. And there's also subvalvular apparatus like chordae and papillary muscle. So with this chordae works as the connect the valve to papillary muscle tips. So there's some classification like primary, secondary, tertiary. So primarily is attached to the leaflet tips, and it maintains the coaptation leaflet. So the failure of this type of chordae leads to rupture or elongated chordae. Next is tricuspid valve. Tricuspid valve is the largest heart valve and consists of 3 leaflets like this, but sometimes it can be the quadricuspid. So it has anterior and posterior leaflet like the mitral valve, and the septal leaflet is different. So it is anchored to septum, and which is with reduced mobility. So septal leaflet attached chiefly to the ventricular septum, but the part of it, basal attachment is to the posterior wall of the alveoli. There's an anatomical variation like this. So up to 20% of patients may have more than 3 leaflets. So like this, variability is common, so it can complicate H2H repair. This figure shows a tricuspid annulus. A tricuspid valve is surrounded by highly dynamic annulus that is prone to significant dilatation, and it is affecting device stability during intervention. Annular size and shape affects device selection and procedure success. Understanding this anatomy is essential for planning successful intervention. So for the transcatheter consideration, annular size and shape affects the success. As a mitral valve, it has several apparatus, but the thing is that if the patient has a CIED, lead impingement from the cardiac device can interfere the leaflet motion, and then it can make regurgitation. And I will compare those two valves. So the mitral and tricuspid have distinct anatomical difference. The mitral valve is bileaflet with rigid saddle-shaped annulus, while tricuspid valve is trileaflet or larger, more flexible annulus. Mitral annulus commonly exhibits calcification, which helps the device anchoring, but it is not for the tricuspid annulus. This slide highlights the key anatomical differences between the mitral and tricuspid leaflet. For mitral valve, there are 2 thicker durable leaflets, which is less prone to tearing. And for tricuspid valve, there are 3 thinner anterior posterior septal leaflet with higher risk of damage during repairs. Next is for the procedure consideration. This illustration shows the diversity of approach to the different anatomical functional aspects of mitral regurgitation. So when we select the patient, we need to assess the feasibility. So the anatomy is one of the feasibility. Mitral tear is aimed to improve leaflet coaptation and to reduce ROA. Based on the result of Everest-2, coaptation length, depth, the flake gap width has the condition criteria, which is a favor for the procedure. So like this figure, coaptation length greater than 2 millimeter, depth less than 11 millimeter, flare gap less than 10 millimeter, flare width less than 15 millimeter is considered as favorable. Because we know that the coaptation length less than 11 and the coaptation depth less than 11 and coaptation length greater than 2 millimeter is positive correlation between the post-MR degree. And this figure demonstrates the concept of tenting area, indicating deformation of mitral leaflet. And this figure shows the larger tenting area, the post-MR is increased. And this figure shows when the accuracy is prolonged, it predicts the higher risk of persistent MR. So it is related with how deformity has developed. And also, we know that the procedure complexity is correlated with the stage of mitral regurgitation, tenting height, and tenting area. So we can conclude that like this, there is an ideal and non-ideal candidate for the TEER, like this. And also we have TMVR considerations. So the proximity issue, the mitral valve is close to the strictures like the LVOT and LCX and coronary sinus, so which can increase the risk of obstruction or compression. This figure shows various transcatheter device for the tricuspid intervention. So like TriClip is effective for smaller coaptation gap, and for the annuloplasty, it's ideal for the significant annular dilatation. Like this, we can use the anatomical challenges. So there is a 6 procedural consideration. The one is annular dilatation, more than 40 millimeter, and the second one is device malformation. If the valve has less annular calcification, the malposition and embolization can occur. And third one is leaflet tethering and coaptation gap. Like severe leaflet tethering and coaptation gap greater than 7 millimeter is associated with a poor outcome. And there's also risk of RCA impingement because RCA runs like the posterior part of the T valve. And there's also conduction disturbance because between the mitral valve and aortic valve here, there is a LV node, so it can develop AV block. And the last one is CIDD related TR. So there is a interfering or non-interfering type of tricuspid valve, but the progressive RV enlargement or annular dilatation can exacerbate TR, and papillary muscle can entangle with the subvalvular apparatus, so the TR is getting developed. So with the summary, mitral valve is aware of LVOT obstruction, and mitral annular calcification can be anatomical barrier. And for tricuspid, large annular size, anatomical variability, and lead interference from the pacemakers can be anatomical challenges. So I'd like to introduce further direction of the research. We can use deep learning AI for the imaging analysis. And there's plenty of works they are doing. And the further one, personalized valve designs. So we can use a 3D image to make a personalized valve design, and we can apply to the patient in the future. So personalized approach based on the patient-specific anatomy is needed. So this is a last slide and summary. Mitral valve considerations are LVOT obstruction risk, mitral annular calcification, subvalvular apparatus, and tricuspid valve considerations are large annulus and anatomical variability of the leaflet, and lead interference in CID-related TR, and proximity to RCA. Thank you for your attention.